post clinical diagnosis is the next heading. Okay, so now when we talk about the post clinical diagnosis, right, now in the post clinical diagnosis we have, first thing is we take a diagnostic cast from the patient, right? So post clinical diagnosis is after you have evaluated all these clinical factors, okay, all of these clinical factors which we discussed till now. Okay, once you have evaluated all these factors, now you go on with taking a diagnostic impression for that patient, and for that purpose what we use is we use our stroke trays or the perforated trays for alginate or alginate material, right? You take the impression, pour the cast, okay, nicely trim the boundaries, everything, and then the next step is surveying of the cast, surveying of the cast as well as mounting of the diagnostic cast, mounting of the diagnostic cast is necessary. Now these 2 points again are very much important in the derived diagnosis part, because why? Surveying again will be covered as a separate chapter or a separate lecture of an hour where there are a lot of things. Just to keep in mind that what we'll do in the derived diagnosis is you take the impression, pour the cast, trim it, keep it ready, then place it on your surveyor, survey, determine the path of insertion, the undercuts, the contour of the teeth, everything what is pertaining to surveying we'll be discussing in a separate chapter. Apart from surveying, what you do is you mount the diagnostic cast, okay, and you mount and check the position of the teeth, the occlusal status of the teeth. So what all you check? First you check is the position of the teeth, the edentulous space available, edentulous space, okay, that is the amount of space available to place the teeth. Suppose in this you can see very minimal amount of space is available between maxilla and mandible. Why? Because these tuberosities are bulbous, so you need to check the tuberosities also. Sometimes due to this you will have, if they are bulbous, there will be less space and the RPD will not accommodate properly, or it might break because it will become very thin, right? So that much force cannot be withstanded by that thin amount of acrylic plate, okay. Moreover, you also evaluate the occlusal status of the teeth, okay. The occlusion, if you want a better view, you can see it from the behind back of the articulator and see from the inner side. That is what the articulators provide as a provision, right? We can see the patient's condition in our hand. We do not require the patient to be with us for the whole time. So that is all the things which we evaluate in the diagnostic cast, and moreover it also helps in patient education also, right? So firstly it gives you an adequate analysis, and also patient education can be done. You can explain the patient what is actually the problem and what is the requirement or the correction you will be doing, right? So this was about your post clinical or derived diagnosis. Now based on all what you have got, okay, the data of your first examining the patient, then periodontium, endodontically, surgical, everything, every aspect, once you have received the data from the patient, then you go on with your impression making, cast pouring, cast fabrication, surveying, mounting and evaluating all the parameters. Now you have a picture in your mind and you can take a call about the treatment planning of the patient, for that patient, for the prosthesis. Now any prosthodontic treatment plan, okay, any prosthodontic procedure you do, okay, it has a sequence of treatment planning, okay. So the treatment planning, now the treatment planning is divided into various phases. We have phase 1, phase 2, phase 3, phase 4, phase 5 and phase 6, various phases. Phase 1 is what? Collection and evaluation of the diagnostic data, treatment of any emergency conditions if it is present, if there is any pain, infection, right? If the prosthesis is there already, the patient is having, you need to determine that the prosthesis is fine or not, and you need to ultimately motivate the patient that whatever the problem is, we are going to solve it together and it will be fine. That is your phase 1. Moving on to phase 2, it involves your pre-prosthetic mouth preparation, making of primary impression, patient motivation. Again, phase 3, then you design the RPD, then you do a prosthetic mouth preparation, making final impression, patient motivation. Phase 5 you fabricate, and phase 6 you insert post insertion management and periodic recall and review should be done. So this is how you move on to the sequence of treatment planning. Right, now there is pre-prosthetic mouth preparation. That is again a separate topic, so we are not discussing that in detail as of now, okay, because that is again a long answer which can be asked separately. So if I just brief it out, it won't be a clearer, you won't have a clear vision about the topic. So the part of surveying and the part of pre-prosthetic mouth preparation, we'll be dealing it separately in a different lectures, okay. Apart from that, everything is covered over here. Now what we are left with is, we are left with the common problems faced during the treatment planning. So what are the common problems you might face when you are planning the treatment of the patient? So first commonest problem is the supra eruption of the teeth, right? Supra eruption. Now for the supra eruption, as we discussed in the flowchart of consequence of tooth loss, we have mild, moderate and severe form of supra eruption, right? So based on that, you decide and take a call that what is to be done to that supra erupted teeth. As I told, sometimes you can do an intentional RCT, chop it off, reduce the height of the teeth and use as an abutment of overdenture also. Sometimes you might also encounter tilted teeth. So now this is a slant proximal area, this is a straight proximal area. So if you are having this much wider size over here, you cannot pass it freely from this narrow gap, right? You need to make both the surfaces parallel to each other so that the RPD comes and goes out freely and passively. So you need to do enameloplasty. Some amount of teeth is grinded with a diamond wheelstone burr, okay. Using your aeroter, you make the surfaces parallel and see that there are sufficient space to accommodate the teeth and everything. Sometimes the molars will be extremely tilted, right? Extremely tilted molars you might get. You might have to chop this sharp cusp of the palatal area, round it off so that it has a good occlusal relationship with your RPD, right? So that also has to be kept in mind. These are the common problems which we come across during treatment planning. I'll write the heading over here: common problems faced during treatment planning. Sometimes you might encounter a grossly decayed teeth, right? And now when we talk about grossly decayed teeth, you have an option of onlays. You can always go with onlay preparation. That much part of the teeth is nicely prepared to receive a good tooth form or structured restoration, right? So onlays can be always used as a preferred option. It is usually indicated, the onlays are indicated in the cases of supra erupted teeth, right? So if I talk about the indications of onlays, you have supra erupted teeth, or you have a severely attrited teeth, or again you can include teeth with inadequate height, or a grossly decayed teeth like we saw in the above diagram, okay. So these are the few indications of your onlay, right? Now one consideration which you should keep in mind is, suppose you are giving an onlay restoration, when you are suppose taking this as your abutment on the teeth which you have selected for onlay, that is your abutment, and you are going to place a clasp. The retentive tip of the clasp, the last tip, should be on the enamel surface, not on the surface of the onlay, because this tip is going to exert forces which will dislodge the onlay, right? So the clasp tip should be on the teeth, not on the onlay, so that it doesn't pull the onlay out from the teeth, right? If not onlay, you can also go with a full coverage crowns, right? Because it is not necessary that every time you have a grossly decayed teeth and you go for onlay. No, there are cases where you will not be able to go with onlay. In that cases, you have to go with a full coverage crown and then fabricate a RPD over it, right? Then next is endodontically saving the teeth, because what happens is, suppose in this scenario A over here, right? In scenario A, you have a distal teeth which is grossly decayed but can be saved by an RCT and onlay preparation, and then can be used as an abutment teeth for placing two teeth as an RPD over here, okay. So if you are not having this teeth, this becomes an distal extension RPD. You don't have a distal teeth for support, right? In that case it becomes a tooth and tissue supported RPD. Okay, when it becomes a tooth and tissue supported RPD, it will not be as intact and as tight as it was like a tooth supported, because tooth supported RPDs take support of the teeth from both the sides. The tissue supported take the support from the teeth and also support on the tissues. Tissues are compressible, right? So the RPD will be more tend to flexion than a tooth supported RPD. Similarly, if you have an anterior teeth and if you can save it, you should save, because it breaks the edentulous space into two different parts, act as an additional abutment teeth, right, and provides good amount of support and retention. Similarly, if the teeth are severely supra erupted, right, in that cases what we can do is we can trim off the teeth, as I mentioned earlier, to the level of occlusion as it permits, and then go with a crown. If you need to reduce more, you should go with an intentional RCT and a crown, and then go with the fabrication of your prosthesis. Sometimes you are not left with any option. You have only option is extraction of the teeth and then followed by healing. You can go with an RPD. More severe invasive treatment options like orthognathic correction. Okay, orthognathic correction. You can move the mandible and maxilla front and back based on what kind of relationship we want, right? We want a class 1 relationship. So in the case of prognathic maxilla or a prognathic mandible, you might have to go with a orthognathic surgery option, but usually for an RPD such invasive treatment option is not preferred, right? Now one last thing which is left for this chapter is that you can also use splinting of the teeth. Splinting of the teeth is done usually. Why is it done? Because to provide a provision for what? Provision for periodontally weakened teeth, right? So when we come across with a periodontally weakened teeth, you want to save the teeth, you want to fabricate a good RPD, you don't want to deliberately extract the teeth. In that case, what we can do is we can go with splinting of the teeth. So when we talk about the splinting of the teeth, again splinting can be of various types. It can be removable splint, it can be a fixed splint, or you can use as an overdenture abutment. Ultimately it is also a type of splinting, overdenture abutments, right? So this splinting can also be used so that you can effectively join all the teeth, take an even distributed support from all the different teeth which are available, right? You can do with a fiber, you can splint the teeth with an orthodontic wire. Ultimately the aim is the teeth should be splinted. So if suppose two teeth are mobile, suppose these two teeth are the culprit, okay, and what you do is you additionally take one or two teeth on either side which are sound and good with good periodontal condition, so that the support or the stress is divided equally to all the teeth and not concentrated on a periodontalically weakened teeth. Only thing is, when you have a teeth which is more severely affected by its periodontal condition, like there is more than 50% of recession, the crown root ratio is not proper, then there is no point of splinting those teeth. But the teeth which still have a chance to survive and play a better role in the oral cavity to support and contribute in your removable partial denture, surely you can think of splinting the teeth either in a removable or a fixed way. So this was all about the diagnosis and the treatment planning which is involved in fabricating a removable partial denture. So just before ending the class, brushing up the highlights what we discussed and what are yet to be discussed in the coming lectures. So yes, we have discussed till now majority of the topics. Only two things are remaining, that is surveying and pre-prosthetic mouth preparation. We discussed the consequences, the clinical diagnosis, we discussed the treatment planning part. The pre-prosthetic part is remaining over here, right? Evaluation of the diagnostic cast is remaining. We saw the orthodontic malalignment, enameloplasty, crowns, fixed splinting, removable splinting, overdenture abutments, right? You can go with enameloplasty, onlay, crowns, extraction, surgery, endodontic treatment. Okay, so all of the things are discussed apart from this pre-prosthetic mouth preparation, which is a separate chapter, and also surveying a separate chapter. So I hope you guys have understood and got a good idea about what this chapter is. Usually we don't get much questions or long answers from this, but to have enough knowledge, the clinical scenario, and to know that what we actually do and how to decide when we are in clinics. That is why this chapter is important. Thank you so much and see you in the next class. Till then, bye bye. Take care.